Good morning, everyone. It is Friday, February 25th. Welcome into the Morning Medical Update. Thank you so much for joining us here on Facebook, Twitter, and on YouTube. Today, we drill down on a new study that shows how Kansans really feel about vaccines, religious exemptions, and what they think the future of vaccines should be. But first, taking a look at some headlines this morning, discouraging news from recent research that predicts worldwide the number of people with Alzheimer's will triple to 153 million by 2050, with 10.5 million of those cases in the U.S. The Alzheimer's Drug Discovery Foundation says smoking, obesity, and high blood pressure puts you at a greater risk. Looking to get the most out of your next flu shot or COVID vaccine, take a long, brisk walk afterwards. It's supposed to help with some of those after effects. Researchers at Iowa State University say that people who exercise moderately for 90 minutes right after vaccination produced more infection-fighting antibodies. They also say, of course, more studies are needed. A government report just released shows women of color died at significantly higher rates from pregnancy or childbirth during the first year of the pandemic. The report from the National Center for Health Statistics does not mention the pandemic necessarily, but experts say it did play a big role in those increased deaths. The mortality rate was highest for African American women, 3 times the rate of Caucasian women. Get your questions sent in to us this morning on YouTube, Facebook, and the Medical News Network. Links to those are right there on your screen. Let's get now to Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, joining us with our COVID count. Happy Friday.
Hi, happy
How are you?
Friday. I'm good.
Good.
Still holding lower cases than we were, say, 2 weeks ago. We do have 49 active cases right now, with 10 in the ICU and 3 on the ventilator. We do have 75 in that recovery period, so a total of 124. But unfortunately, Jessica and Steve, we continue to have deaths. We had 2 deaths over the last 24 hours. That brings our total for February to 43 total deaths. So.
And just to say, we got down into the 1-teens.
Mm-hmm.
Now we're back up around 124. We got down into the low 40s, up to 49. It just feels like we've hit a new plateau right now. We know the CDC is set to relax masking guidance across the United States, which I think in many ways is good. People want to get back to a sense of normalcy. And they also said, and this is an important change in policy, guys, they're going to change the recommendations around masking, and they're going to base it on hospitalizations as opposed to the number of tests that are positive, which I think makes a lot of sense. We've said that for a while. The real crux of this right now is you shift from a pandemic to an endemic. How do we live with COVID, and how do we adjust to the ups and downs of it is going to be based on whether or not you have what your capacity is in hospitals. And so I think we know that when deaths start occurring and when the hospitalizations build up, deaths start occurring, not just with COVID, but with all the other diseases as well, because as we've heard before, you can't get access to the highest levels of care. So Hawkeye, I think this is a reasonable change by the CDC. It does lag behind the most current thoughts a little bit, meaning that hospitalizations lag 2 to 6 weeks behind where the pandemic is or where the endemic will be, as it becomes more of something we have to adjust to on a daily or weekly basis, Hawk.
Yeah, I think that's right, and we are seeing all across the nation those trends were lagging, as we said, cases, then hospitalizations, and deaths. But I think you're right on those points exactly. So.
We also expect that the CDC will be lifting guidance around airplanes and airports in the near future, or at least not renewing it, which means that there's a sense where we're returning to almost complete normalcy, but we're not really back to normalcy, right? We're back to our new normal, having to make sure we try to coexist and live alongside COVID-19. The other good things, always new therapies, whether it's monoclonal antibody therapy or by prescription drugs like Paxlovid, including that's becoming more widely distributed now. It's available here at KU. It's available through other pharmacies.
Yeah, exactly. I think we have been waiting for this type of time period. We talked early on in the pandemic, Steve, about we would like something like for influenza that we have with the over-the-counter Tamiflu, not over-the-counter, just as you said, but by prescription Tamiflu, the oral pills that we can use early on in disease, because we know hitting the disease during that viral stage early on with these oral antivirals, Paxlovid, Molnupiravir, have shown to have benefit in good peer-reviewed studies, but also those monoclonal antibodies, and there has been a number of different ones throughout the monoclonal antibody period, but we know earlier is better. Certainly within 7 days is going to be the best treatment to help reduce your chance of hospitalization. But I think we've been waiting for this. And now as the cases go down, hopefully the local pharmacies' supplies will increase. And when and if there is another surge, people will be able to use those to help stay out of the hospital.
And also some changes to the immunization vaccination recommendations, a little longer intervals for certain disease groups, going from 4 weeks to 8 weeks to lower the risk of myocarditis, although very rare. This lowers it to the point of eliminating it. And actually, by waiting longer, you get a better immune response. So I think these are both good. I think this is all good news for us in general. And we'll see how we go as things begin to relax, Jess.
All right. Reporters on the line today?
Sherman Smith from the Kansas Reflector.
Hi, good morning.
Good morning. I wanted to ask about this planned early COVID treatment symposium in Lenexa next week, which is all about ivermectin and hydroxychloroquine. And I just wonder if you're concerned about this growing profile among the people who are spreading inaccurate information, and whether there's any value in engaging with the people who peddle this kind of information.
Yeah, fair question. So here's the reason. Here's my sense. For the longest time on this program, we've said we're not going to be flapjackers, right? We're not gonna flap our arms and jack with the truth and trying to speak wildly about it. Instead, what we're going to do is try and stick as best we can to this science, and we'll let you know when we're talking hard science. We let you know when we think we're giving you our more of our professional opinion. Here's what we know. The evidence that was published, not this last week, but the week before, in the New England Journal of Medicine, looked at Paxlovid, which is a combination of two different drugs. And it demonstrated an 85 to 90% reduction in hospitalizations and death. That's really good, right? That's like really, really, really good. Now, if you look at the data that has been suggested about ivermectin and hydroxychloroquine, the data, it's just not there. What you have is a lot of personal testimony that says, gosh, I was feeling poorly, I took ivermectin, and then I started feeling better. The problem with viral illnesses is that's always true, right? You're feeling poorly, and then you start feeling better. Well, was it the ivermectin, or was it not? And so when people have tried ivermectin and hydroxychloroquine in randomized blinded trials where you didn't know what you were taking, what they found is there really was no difference between those who took it and those who didn't take it. And so we're going to stick to the science. We're an academic medical center. That's what we do. We're going to describe the science to you. In this country, you have personal choice, and you can go choose to try and find medications like that. The problem is that if we're going to stick to the science, we have to stick to the data and the things that we know are available. The second thing, and this is the other concern we have, is that there is a healthcare system that is built on principles and checks and balances. I studied for years and years and years to get degrees. I have to take boards. I had to take my pulmonary boards again last year because I had to recertify. Hawkeye just took his ID boards because he had to recertify. And as we do that, you have to continue to study and continue to learn. And when we do that, you recognize that the system of checks and balances between hospitals and pharmacies and nurses exists to protect the patients. Because patients haven't studied, individuals haven't studied the science for years and years and years, right? They don't have to go take board exams to try and figure out if they're doing the right thing. Unfortunately, people read the internet and Google becomes truth when the reality is, I love Google as a search engine, but let's be honest, Google is goo. Right? It's got as much truth in it as goo has. And if you stand back, you ask yourselves, we got this system of checks and balances, or am I going to go read the goo and figure out what I want to do? Goo-do. And I think goo-do is a bad plan, because you read it on Google, goo, and then you want to go do it. And I think what the struggle we have is that when folks introduce bills to say, if a patient asks you, you have to give it to them, or if the pharmacist has presented a script, that have to give it to them, then at the end of the day, that's goo-do. Because these folks have not spent the time to try and study the science and really delve into it and have to take boards and do all the stuff that people say. So again, in the United States, you can go ask somebody for it, and if somebody wants to write that script on an off-label use, and I've used off-label drugs and cystic fibrosis before, You sit down, you explain to the patient what's going on. You say, I don't know if there's any evidence for it. And then you try and find somebody to fill it. Okay, that's off-label use. It's an approved drug. You can do off-label use. But if you step back and you say, what are you reading on Google and what are you reading in hard science, where folks have been blinded, they didn't know what they were getting, and then they measured how many times did the people who were blinded and didn't know what they were getting, how many times did they get better? Okay, and if they got better, were they taking the placebo or were they taking the drug? The struggle with ivermectin is that when they did that, placebo and ivermectin didn't show any difference. When you look at Paxlovid, there's an 85 to 90% reduction. Hawkeye to me, that's case closed.
Yeah, I would totally agree. I think you touched on a number of good points. Number one, sitting for boards and doing your training. You know, I'm trained to treat infections, understand virology, pharmacology, the mechanism of action of these drugs. I'm not going to be treating lung patients like you and cystic fibrosis patients like you because I don't have that training. So I think that is one important point. The other important point is, you know, a lot of this, we have seen this before, and I would make it akin to you know, those gentlemen that would travel with the circus or in their wagons with their elixirs that would solve any of your problems. So I think there is a lot of anecdotal or hearsay evidence, but when we really basically get down to, and this is what we actually need to do, is keep the issue at hand, keep it in our vision so that we can understand what is the issue. And just as you said, the issue with hydroxychloroquine and ivermectin for treatment or prevention of COVID-19 or progression of COVID-19. And really, that door has been shut for hydroxychloroquine for some time. That has been shown unequivocally not to have any effect in preventing COVID-19 or progression to severe COVID-19. You mentioned ivermectin. So I think there's a concern that we are the only ones who are saying it's not ivermectin. Well, we are taking our guidance from people who do this every day, all day, understand and know how to scientifically critique articles. And right now, the vast majority, the overwhelming support or lack thereof support for use of ivermectin is currently there. You know, there is not a good body of evidence to support that. We have recent abstract from the Together trial, I believe, the abstract from CROI, which is a large international infectious disease organization that has been around for some time. They had an abstract at their meeting recently that looked at the final study, the Together trial, I believe it was. And that is the same trial that found some effect, beneficial effect of the use of fluvoxamine. But when they finally did all of the analysis, it had no effect when they used ivermectin. In addition, we know that JAMA last week produced or published the ITEC trial looking at use of ivermectin and progression to severe disease for COVID-19. And in that trial, ivermectin had no beneficial effect at all either. And these, again, are peer-reviewed. They are critically looked at studies, so they understand that. There was also a meta-analysis that was originally published, I believe, in January of 21, July of 21, that showed some benefit, and a meta-analysis is looking at a lot of different studies. However, that article had to be rewritten because once they pulled out those articles that were taken out of publication, meaning retracted because of falsified data or inaccurate data, that meta-analysis also showed no beneficial effect of ivermectin on the progression or prophylaxis of COVID-19. So I think those are large studies, and we're waiting for the full publications, obviously, for the Together trial. But none of these large peer-reviewed, critically reviewed studies show any benefit. The other thing that we're looking at, again, is we are taking guidance from our other bodies that really look at this. The NIH has looked at this and said, do not use this in outpatient or non-hospitalized patients for treatment of COVID-19. That is on their NIH guidelines. What are those drugs that are used for non-hospitalized or outpatients, Steve? You've talked about them. Paxlovid, molnupiravir, the monoclonal antibodies. Those are the recommendations in the NIH guidelines. The World Health Organization, I looked yesterday, continues to say do not use ivermectin unless it is in a clinical trial, and we would be all for that. We want clinical trials. You have to register under clinicaltrials.gov, I believe. But it is a way to do that so that we can get accurate information. And this is what is done in all of science and medicine. This is done for all of our drugs. So I'm not sure how we can say for our body of medicine and evidence-based, we can use that for every other thing that we're doing in medicine, this evidence-based, this clinical trials, but not for this.
And I think
that's an indictment on the system.
I agree. And Hawkeye, the last thing I say is, I think people are afraid, right? They're afraid of COVID. They're afraid of the ramifications of it. And they're also afraid of some new things. And I get that. When brand new medications come out, I'm not the first guy to rush to use it. I like kind of sit back and say, let's see what happens with the post-marketing part. Let's say, or the post-study part, and let's see how people do. But then you have to weigh that against the urgency or the emergency in that time. And during a pandemic where we've lost almost 1 million people in the U.S., that's a more urgent time. Being afraid of something, though, doesn't mean you should be on its face for something without evidence. You can say, well, ivermectin's safe. You know what? Ivermectin is generally safe, right? We've been using it for generations. That's great.
Yeah.
But it doesn't make it right for diseases. And it makes it right for parasitic diseases. I have no doubt, you bet. But is it right for COVID-19? And as somebody who's been studying this kind of stuff for a long time and had to spend my life doing it, we step back and we look at the data and we say, gosh, it doesn't look like it's safe for COVID-19. But here are all these other therapies that really are safe for COVID-19, including vaccination, including monoclonal antibodies, including now Paxlovid, Molnupiravir, and Remdesivir, and others. And now we give Remdesivir as an outpatient. So I think that being afraid of something, I do understand that. I really do. We talk to patients all the time. And we do this this is our life. This is what we always do. And just to clear up some other misinformation, I don't ever give drug company talks. I don't get any money from drug companies. I don't do any of that. And so when I give you these opinions, these are not out of financial interest to me. And if anybody's even more concerned, just know that when you practice as a physician, you can't get reimbursed because the health system makes more money. That's illegal. People go to jail for that. And so at the end of the day, we're just trying to recommend to you what we think is the best thing.
Yeah, and I would, I love that point you made about, ivermectin is a great drug. A lot of these drugs are great drugs for what they are intended for. Right. So I kind of make it akin to, we know oil for our car is vital and a great thing to have. We know what it's used for. But in this case, if we have an empty gas tank, we are not going to pour oil in the gas tank, hoping it's going to start our car.
That would be bad.
So, we are using it for what it is for, and for what it is for is a very good drug. But if you're looking certainly for this viral infection, this has not shown, again, in the critically reviewed, the peer-reviewed studies, have not shown to have any benefit. In fact, in that JAMA Internal Medicine article that was published this past week, there was actually 21% of the ivermectin group went on to progress to severe disease, as opposed to 17% in the people who did not get ivermectin. And so is there even a little bit of increased chance of progression? That was not statistically significant, but I think that's an interesting number to show as well.
All right, I do want to ask the reporter's other question, which was, is there any value in engaging with these groups that are holding these type of gatherings and meetings?
Yeah, I think this is a question of process, Jess, and I think that when we do debates in academic settings, we tend to put the experts in a room and do things like a journal club or sit down and have discussions around it. We don't try to run out into public forums where cameras are clicking and things like that and do sound bites. That's just not who we are. It's not what we do. It's what other people do. That's fine. Go for it. But that's not who we are. And I think what we prefer to do is hold a journal club. Within the university, we sit down, we have these long discussions about stuff. Hawkeye, infectious disease team has a journal club, and you sit down, you review these articles, you critique them, you listen to outside people, you go to medical conferences with the top researchers in their field, and you have honest ongoing discussions about that information. And I don't, trying to go to a setting in which it's more of a public forum, again, a lot of news cameras and things like that, that's not who we are. We're not politicians, and I don't mean that in a disparaging fashion. That's another type of job, and I'm not in that job. This is my job, and I'm going to try, and I think I just need to do my job. And God bless the people, and Godspeed to the folks who want to be in the political world. I think that's a really hard job. And you have to respond to a lot of things. Well, what we have to respond to is what we know is a system of science that makes the United States the leading producer of science and facts around science and medications and studies around medications by far in the world. It's why everyone in the world looks to the FDA to say, what did the U.S. do? And that's not by mistake. That's because we have a process for looking at these kind of questions and answering them. And I think that's, and then the second part of it is when we meet and talk with our patients, we're talking about the science part of it. So if you want to get together and talk about it, Godspeed, go for it. It's just not who we are.
All right, we're going to talk more about this next week, but I do want to get to today's topic and our guests because they're really good. This is very interesting and some interesting findings. I want to hear what you have to say about this, but let's get to them. The COVID vaccine has been a polarizing topic, as we know, but does it really speak for public opinion towards all vaccines? That is a question Nurture KC needed answered, as their work is dedicated to getting people, especially moms-to-be and infants, protected. Using an immunization grant, Nurture KC commissioned a statewide poll conducted by Public Opinion Strategies to determine where Kansans really stand on vaccinations that have protected us for decades. Joining us with results on this recent survey is Tracy Russell. She is the Executive Director of Nurture KC. Good morning to you. And also we have Dr. Stephen Lauer. He's a pediatrician here at the health system. So glad to have both of you. But Tracy, I want to get right to you and get to some of this research results. So tell us a little bit more first about what Nurture KC is, their roots, and who you help in our community.
Well, thank you so much, Jess, for having me on today. And Nurture KC serves both Kansas City, Kansas and Kansas City, Missouri. It is a federally funded program for the most part. And our mission is to reduce infant and maternal mortality in Kansas City. So our flagship program is called Healthy Start. As I mentioned, it is a federally funded program. There are just 101 Healthy Start programs across the country. So we're very fortunate to have that program here. And we serve pregnant women and their children from the zip codes of Kansas City with the highest rates of infant mortality. So that's 14 zip codes across the metro. And we deploy a community health worker model so that these families are getting that one-on-one assistance that they need. And, you know, when I'm asked to describe what we do, it's just so encompassing in terms of meeting these families where they're at and helping them navigate many of the barriers that they face. We provide car seats for our families. We provide diapers for our families. We help get them into the health system. We provide cribs as well as training on safe sleep. And for me, I think the beauty of Healthy Start is there's a very rigorous data collection component to it. So we're measuring our outcomes. We've got benchmarks we have to meet, as well as serving over 700 program participants each year. And so, you know, we utilize that data so that we can adapt as needed and pivot if we need to, if we feel like there are areas where we're falling short. So we're very proud to be associated with that. So that's definitely a direct service model that we utilize. Our second primary program, and the one that we're going to talk about a lot today, is the Mid-America Immunization Coalition, or MAC for short. And that has a broader geographical reach. So we serve Jackson, Clay, and Platte counties in Missouri, and Johnson and Wyandotte counties in Kansas, providing education and advocacy around the importance of vaccination. And certainly that plays into our Healthy Start program and wanting to ensure wellness for these babies and their parents. We also provide direct service there as well. We host flu clinics every fall, giving out free flu vaccines. And we did add COVID-19 vaccines starting last spring, and we continued that through the fall. And we had hosted a clinic here at our headquarters in Kansas City for the families in our Healthy Start program, recognizing the importance of pregnant women in terms of getting that COVID vaccine for the health and safety of them and their babies.
Tracy?
So, yes.
Okay, tell us a little bit about how your organization is funded.
Sure. So the bulk of our funding comes from HRSA through the federal government, and that runs on a 5-year grant cycle. We're actually in our 4th 5-year grant cycle. And then we also receive some local foundation funding. United Way is a supporter of ours, Health Forward Foundation. And then we also do receive immunization funding through the state of Kansas as well. And we do have a membership component, so we do have some dues collection and, of course, participate in Giving Tuesday and events like that to raise additional funding.
So a professional polling company did this survey. I want to start off with just kind of the methodology and the demographics of those who responded and what you were trying to gain better understanding from.
So we wanted this to be a scientific poll. That's why we utilized public opinion strategies. They are a very well-respected national pollster, but with some Kansas ties. This firm has done polling for some of our current and former U.S. senators in the state. And we wanted it to be reflective of the state at large. And so those demographics were very important. And what we've ended up with is a poll that has a margin of error of plus or minus 4%. As you can see from this breakdown, 52% of respondents were women, 48% were men. And then we also wanted to test on all of the age groups. You know, there's been a lot of conversation around, does support for vaccination correlate to age? You know, and even how it breaks down along party lines as well. And again, wanting to be that reflective of the state. There were 600 respondents to this poll, and it was out in the field January 27th through February 3rd. So this is as current information as we're able to get. It's really real-time information. As you can see from the geography, we tried to hit the quadrants of the state. So Kansas City, Topeka, Wichita, and then the balance of the state. And I think this next stat is particularly interesting because, again, wanting to be reflective of the population at large. So 43% of our respondents identify as Republican, 25% lean independent, and then 28% identify as Democrat.
I want to get to some other results as well. 9 in 10 people believe wellness vaccines are completely or mostly safe.
Yes. And, you know, it was interesting when we were discussing taking on this project, because there were some who felt like, you know, with the onset of COVID and how polarizing that has become, would we not see that base of support for routine vaccination? And, you know, and we really wanted to develop this to guide our work in what we need to do and how we might message effectively to encourage this. I think we were all incredibly reassured and even pleasantly surprised, if I'm going to be honest about it, that 95% of Kansans believe that these vaccines are both safe and effective. And that really flies in the face of what we're hearing in the state houses from some very vocal groups. So we were quite pleased with that outcome.
65% believe both parents should weigh in on religious exemptions.
Yes, so we definitely wanted to test around support for exemptions, as that's kind of a growing area where we're seeing attempts to broaden current exemptions as well as expand into new areas of exemption. And Kansas currently has a religious exemption. And we did ask a general question around what is support for that? Well, 56% believe in theory that there should be that exemption, but we wanted to drill down on that because the religious exemption is relatively easy to obtain in the state. And for instance, it does not require two-parent consent to get that exemption. It does not require annual review or renewal to get that exemption. And it doesn't require any religious leader to sign off on that. Well, what we found was 65% of those polled believe that it should require two parents. And there was also great support in terms of tightening those other allowances as well. And so what we're seeing is, yes, there is support for an exemption, but making sure that it's truly an exemption for sincerely held religious beliefs. And, we're seeing efforts to go in the opposite direction of that in terms of broadening that religious exemption. And so we really wanted to take the temperature of the public on that.
6 in 10 do not believe in adding more vaccines.
This is a very important statistic as well. We're seeing efforts to put in a new exemption around perhaps philosophical objection. And we're finding that this is not popular with the public. More than 6 in 10 don't want that. And we had tested particularly around the message of, do you believe that parents ultimately need the freedom that comes with those exemptions? And should that kind of trump any other consideration? And there was a resounding no to that. There was much more support for kind of protecting the herd and serving the common good through vaccination and not allowing these wide, broad exemptions.
Another highlight was that 85% of the people polled believe that the KDHE should be the organization that sets the wellness vaccine policy for children.
For me, this is one of the most fundamental measures that we needed to take. For the last several sessions in Kansas, we've seen attempts to move that authority from KDHE and place it in the hands of the legislature to determine vaccine policy. And I think it really goes to the heart of what we're talking about today in terms of who do we trust to set these vaccines? Do we trust the science and the evidence, or do we discount that? 85% is an overwhelming endorsement of keeping that right where it is. And even when we tested messaging around it, it came back to, we want experts in vaccines. We want to follow evidence-based best practices. And this really runs counter to a lot of the messaging that we're hearing from these vocal minorities. And I think it's incredibly important for vaccination. It's incredibly important for anything health related. When we're talking about what has been the pillar of public health in terms of prevention of disease, it's been vaccines. And that still resonates with the public. And that's who they trust to maintain that.
Well, and I'm going to ask you lastly before we bring it back here and talk with our doctors and get their opinions on what you've shared. But you did ask who pollsters trusted most when making decisions around vaccination, and it was doctors.
Absolutely. Well, and we also asked where people are getting their information when it comes to vaccination, and it is overwhelmingly still doctors and health providers. I was a little nervous in terms of, are we going to see huge margins of people getting most of their information via the internet? That pan out in this poll, it still remains those healthcare providers are the most trusted source for this information and the go-to for this.
So Dr. Lauer, that has to be some good news on your part. I want to ask you, after hearing some of these results, surprised, not surprised? What is your take?
Well, I was actually really encouraged by these results. As Tracy mentioned, I think much of the messaging we're hearing now is from a very small vocal group that gets kindly put, a bunch of misinformation in front of people. And so the results, when you actually get to the population and talk to people about what they really believe, to see these kind of results is really encouraging. What I'm taking from it is that the people of Kansas believe what they see. And, or more precisely, actually, they believe what they don't see. And what they don't see is smallpox, polio, measles, H flu, meningitis, pertussis, all the diseases that their grandparents lived in fear of for their children getting. The people of Kansas today do not see those diseases because of the success of the vaccine programs and the way that families have worked with their pediatricians and family physicians across the state to make sure their kids are vaccinated and safe. So it was very, very encouraging after 2 years of the pandemic and, as Tracy said, a big increase in all the misinformation around vaccines, to see that people can still get to the core of things, really get to the truth and understand what's best and safest for their children.
Dr. Lauer, are you still getting resistance, though, in clinic from parents? Questions?
Questions always. And hopefully we always say we want questions from people. We know there's a lot of information, a lot of stuff out there that people hear, and they should have questions about how best to care for their children. We're always want to be engaged in those kinds of conversations with people. So there's a lot of questions, of course, and we can answer those. And we're glad to have those conversations and reach a mutual decision with parents about what to do. The resistance is actually, again, it's a very, very small group who just are totally opposed to this. And most parents either understand the effectiveness and safeness of the program or have good questions. And after some careful discussions with their child's care provider, they understand what's the safest and best thing to do and proceed with the vaccinations.
Well, and you're my kids' care provider, so I always come with my list of questions, and you're always so happy to answer them, I know. Dr. Seitz, some comments from you as well.
Yeah, a couple thoughts. So first, I think one of the things that is happening in the U.S. is that people haven't seen the marked challenges that we had in the 60s and 70s when children weren't vaccinated. Yeah. And so now you're 50 years removed from some of that. Mm-hmm. Our parents were all for vaccination in part because they saw what happens with polio from kids. And they saw what happens when you don't get these childhood diseases treated. And that's a different experience. The second thing I'd say, just to be fair, the poll is really an assessment of Kansas City, Wichita, and Topeka. Only 7% were not in those areas, and about 25% of Kansas is rural. So follow-up question would be, gosh, what should we go explore and see what the opinion is in rural areas, and does it reflect the same thing as what we're seeing in this poll in Kansas and Kansas City, Wichita, and Topeka? I think it's a great poll, and I think it's got really valuable information. I'd love to see more of what's going on in some of our rural areas and see if that's also the case, because we know there's been more vaccine hesitancy in rural Kansas than there has been in urban Kansas, and then within urban Kansas, it's been difference between, for example, African American and predominantly Caucasian. So I think this is really helpful, and it is really encouraging, and it is good to see that the majority of Kansans in this poll liked vaccination and believed in childhood immunization, which is a good thing, because it's another one of those things that if you don't find yourself in the Goodoo paradox, in the Google, I'm going to go do something paradox, I read it on Google, then you're going to want to get vaccinated, which is what we want people to do. And we understand that sometimes there are bad results from a vaccine, right? That those occur, they're incredibly rare. But I'll tell you, polio is a lot worse, and measles, mumps, and rubella. Those are really bad diseases, and I think we've lived in this age where we've forgotten it sometimes because we don't see it, and because we don't see it, we don't really think it exists, and then we get all inventive around. We start doing the Goodoo thing again. Laura, I look at Hawkeye. I think you studied this as an infectious disease doc, and Laura will have as a pediatrician.
Yeah, I think that's right. We continue to stand on the shoulders of these giants that came before us, that created what could eventually be these healthy situations by creating these vaccines. not allowing us and my generation and generations since then to have to deal with those those illnesses, but also those complications, which in some cases were less frequent, in some cases were rare, but they did occur, and that impacted children's lives. So I think that is important to understand. We are looking at this whole situation through these rose-colored glasses because we don't have the knowledge of really what it was like during those times.
Dr. Lauer, you've seen it. What happens? What happens when kids don't get vaccinated and they come to your office with these kind of bad disease?
Luckily, these continue to be rare, but that's the big worry. People, if these diseases, as Dr. Hawkins said, they're still there. Measles still causes tens of thousands of deaths around the world. And in fact, those rates of deaths have drifted back up lately. So, these diseases are still out there. They're a plane trip away, as we've proven a couple times in the past few years. So yeah, when kids come into our office and are sick, we were talking with medical students a couple days ago in clinic. It's one of the central questions we ask when a young child comes in ill is, are they vaccinated or not? It totally changes the way you think about manage them if they aren't vaccinated, because their chances of having a truly serious disease are greatly increased. So yeah, it's, as you said, the vaccine program is really a victim of its own success. People, parents in the current age just don't know these diseases, haven't seen them. And so it does raise questions like, why are we doing all this? Is it really necessary? The answer is clearly yes, because again, what we've done is protect children from the diseases. We have not gotten rid of the viruses and the bacteria that cause these diseases. They're still there, and they're waiting to get a hold of unvaccinated patients.
And just there's a reason life expectancy in the U.S. has gone up so much, and it's partly because of vaccination. Take away those childhood vaccinations, watch your infant and childhood mortality triple, quadruple, do this terrible escalation, and all of a sudden our life expectancy is going to go down. And just remember, in the age of COVID, it's already dropped 2 years.
But I'm glad you brought up the polio story, because during this whole pandemic, I heard my mom say, we didn't even ask any questions. My grandmother saw what was happening to children who have polio.
Yeah, it was terrible.
The minute, the day that my mother was able to get vaccinated, my grandma grabbed her, and they literally were lined up around the building waiting in line to get their vaccine. That was 70 years ago, and
it was really bad.
No information,
Look,
just trust.
When I started as a fellow here, which granted was over a century ago, it seems like to most people. It's been a long time. You're like 32
I'm not saying
years.
you remember back
no,
then.
I just but when I started 32 years ago, we still had post-polio children coming in with all the respiratory problems. And, they'd be on the ventilator. Back then we were using iron lungs still and all these things that people laugh about now. And they're like, Stites, you're crazy. Well, okay, maybe I'm crazy. But the reality is we did do those things, and we were treating people with polio who had lived a little longer post-polio. But that was back in 1990. I got to tell you, we just don't see post-polio anymore because of vaccination.
Yeah, and there was that trust and understanding that you went to your medical teams and your physician, understanding that hopefully and believing they were up to date and knew the best information to help protect you and your family. And I think there has continued to be, we've heard our guest talk about the social media aspect, there's continued to be minority but loud voices to help sow that deceit and that distrust in many aspects of our lives. But, and we've especially seen this certainly exaggerated since COVID now, even against your medical professionals who are on the front line, who are here really only to help you and really want the best for you, and trying to do that in what we have been dealing with and looking at and using as our MO for I don't know how many years, decades now, and that is evidence-based medicine, and that is looking at trials, understanding, critiquing, and really getting down to the nitty-gritty and the accurate information so that we can present that to you in a manner and have those discussions as Dr. Lauer has talked about.
We're going to get to some comments and questions from our viewers. We just got a few this morning, but I did want to start with Rebecca's comment. She said she's encouraged to see some of these results. Sometimes the noise surrounding all of this can be very loud, and
The
they
noise
forget
is
that they are in the
really
minority.
loud.
So
The noise is really loud, and how do you separate the fact from fiction? And I feel like that's been our job the whole time, and we try to stay at the fact as best we know it. We always tell you we're still building the airplane while we fly it, so we're going to be wrong. The parts may not fit. I mean, we just try to make sure that we keep that bond going with our audience that says, look, we're going to tell it to you as best we can. When we don't know what exactly is what's right, we're going to tell you that. We're going to give you a little sense of hope and optimism, but we're going to temper it with realism.
okay, question from Isaac, and I'm not sure if Tracy, I don't think this was part of your poll, but maybe Dr. Lauer can weigh in as well. But a question for our guest is, what proportion of Kansans believe that teens should be able to get vaccination without parental consent, as they do allow, I guess, in some states? Dr. Lauer, go for it.
Yeah. Have fun with
I
that one,
don't know.
Steve.
Yeah, thanks for that one. I don't know a number on that. I think there is growing interest in at many levels about actively engaging adolescents, especially the older adolescents, in those decisions around their own health care. You know, nothing magical is switched on your 18th birthday. And so I think that just gets at the question of actively engaging adolescents appropriately in decisions about their own health care and making them a part of those decisions, which is something we try to do in our practice, talking to those adolescents individually, but then reaching some consensus along with their parents about their health care.
Dr. Hawkinson, quick COVID question, vaccine question. Should I get my mom, who is 90, a fourth dose? And Joe says he's obese. Should he get a fourth dose?
Yeah, you know, that's a great question. Again, no specific guidance here in the United States. Dr. Stites and I were just talking this right before we went on the show. There's some early information from Israel and the Israeli data, and again, we know they have been one of the leaders in some of this vaccine information that we've gotten, that showed really no beneficial effect from that fourth dose against infection. Now, we are still waiting for the full data set from Israel and other places. But, you know, it still looks like those 3 doses are what is important for protecting against severe disease and hospitalization. Now, they do have the caveat that the data is early. It is a small data set. In addition, there may be groups such as those elderly groups, especially, 90, but if we're talking, over 60, 65, that may benefit from an additional dose. But what they saw in that initial Israeli study was that at fourth dose really did not increase your antibodies much more. You did seem to hit an antibody limit. We obviously know that immunity is not just antibodies but T cells, but right now the early indication would not support that fourth dose. However, as we get more information, it may be beneficial, especially for those older populations. Again, the main goal is to help prevent against hospitalization, severe disease, and death. And there is some basic science research showing that really three exposures to spike, whether that's through vaccination and or infection, is really important in what is needed to have optimal protection, especially against hospitalization, severe disease, and death. So as of right now, there is no recommendation. Would it be safe? Is it safe? I think we all believe for the most part, yes, it would be safe. But right now, no formal recommendation. We will wait for some more information. And moving forward, there may be certain populations that it may be recommended. But as of right now, nothing is concrete and there is no formal guidance.
Last question is from Melissa. What is the success rate of monoclonal antibody infusions in keeping the unvaccinated person out of the hospital or from death?
Yeah, and I think talking with my colleague, Dr. Barr, who's helped run a lot of our therapeutics groups here at the health system, I think our data is really consistent with the national and the trial data of monoclonal antibodies to help protect against hospitalization. And it is running, I believe, above 95%. So the monoclonal antibodies, when they work, because we know we've had some monoclonal antibodies that haven't worked against certain variants, but it has been an extremely high rate of success in preventing progression to need hospitalization.
Right, we are going to wrap up and get to some final thoughts. Tracy, I'm going to start with you.
We hope that this poll serves as a reset for us in these conversations around vaccine and brings us back to reality and And I have often said that I wear two hats with this. Yes, this is my professional life. I'm also a mom of two high school boys, and I can't imagine a world in which we weren't protecting them from preventable disease. So I would say that we shouldn't be the silent majority anymore, that there's really an obligation to talk about this because we are at a tipping point in this state. And while support for routine vaccination shouldn't be news, it is in 2022.
Tracy, thank you so much for being with us today. Have a great weekend. Dr. Lauer, final thoughts.
With the possible exception of hand washing, in the fight against disease and death, vaccines are the most important invention ever come up with in the history of medicine. They're incredibly successful. They have reduced and wiped out diseases now to the level that most people don't even know the disease that's been wiped out. So we have to be vigilant, keep looking for side effects, understand exactly what's the best way to deliver them. All those things have to continue to be monitored, but we can't get away from the central fact that these are incredibly successful. They're safe, they're effective, and we need to keep advocating for them for our patients.
Dr. Lauer, thanks so much. Always good to have you on.
Yeah.
Dr. Hawkinson, final thoughts today.
Yeah, I would just like to double emphasize that point. Such a great point by Dr. Lauer, and I know we look to him for a lot of our pediatrics questions. And I think it is such an easy and simple message, but it is so true. And I'm thankful for so many things that my parents did for me, growing up and now. But one of the simplest things that you look back on is getting those vaccines. And I didn't realize at the time, but that is just what they did. That is what we did. They trusted the medical complex, the physicians. We did that. We stayed safe. I didn't have, my sister didn't have those diseases and those complications that were rampant, when my parents were growing up. And so, again, I don't think we can emphasize Dr. Lauer's point enough.
Dr. Stites, thank you, first of all, for the new word of the day, goodoo.
Goodoo.
Not doo-doo, but goodoo.
Yeah, it's a bad plan.
I needed that on my Friday.
Oh, yeah,
So
I
heard everything you said today, but that really stood out for me.
It is a Friday day.
It is.
And,
I needed
Friday,
a new
I
word.
get to be a little more inventive and
for
creative.
new word drops.
There you go. It's a day for it. I mean, I wore a red shirt with a yellow tie. What the heck?
What are you doing?
It's all kind of goofy today. I think at the end of the day, right, one of the things we've done in this program is say faith, hope, science. And that's a incredibly strong bond, and part of that is hope and keeping hope alive. We also have to keep history alive. We have to remember where we have come from before we make really bad choices about where we want to go. And if we want to ignore history, we pay a pretty steep price. And that, in this case, that price will be the lives of our children and our young ones. So don't do the goo plan. Don't go goo. I've read it on Google. I'm going to go do it. And by gosh, it's on Google, therefore it's true. And that's probably not right. Instead, we should pay attention to history. There's a reason I love the turn of phrase, live long and prosper. It's because I really do want people to live for a very long time. That's what we do in medicine. We want you to live your best life. It's hard to live your best life. If you had polio, measles, mumps, rubella, and you got really sick from those things, it's really hard to lead your best life if you have long haul syndrome from COVID. These are not necessary things. They're things that can be treated and avoided. But to do that, you can't just base it on the goo-do. You got to base it on the science.
The goo-do that you do?
The goo-do that I do. Yeah. I do goo-do at home. My wife doesn't like that either. Just say. It's a bad plan.
All right, have a good
Live
weekend.
the science, man.
All right, thank you everyone for being with us today. Don't forget you can catch our shows anytime on Facebook, Twitter, and on YouTube. Coming up on Monday, you recognize this voice.
I am the Flying Dutchman.
You know this guy from his famous movie and TV roles. Coming up on Monday, actor Brian Doyle Murray shares his story with us and how his recent role as patient took a more serious turn. We'll talk with him on Monday, everyone. Have a great weekend.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.